Namaskar. A very big good evening to all our respected seniors and all my dear colleagues who have joined us today on CCI's Thursday webinar, Guruvar Guru ke Saath. So today's topic
Namaskar.
is
A very big good evening to all our respected
uh, today's evening is very special because we're
colleagues who have
talking
joined
about
us
something
today
which
on
is very
CCI.
relevant to all of us. Thoracentesis. Well, thoracentesis is one thing which we all as chest postgraduates are, which is one of the first procedure that we come to learn, and it is sort of a romantic relationship that a chest physician has with thoracentesis. So, to increase this romanticism, we have everything from your old times to current times to future times. And to enlighten us, we have a very, very, very bright and special All India panel with us today. Well, to introduce my panelists, I would like to begin. I have a very good panel today, and the best part is that thoracentesis is one such thing that every chest physician has something or the other to contribute to us about it. So, really, in the question box, I would request all of you to act as faculty and give us your suggestions and questions also. So please be with us because for me, thoracentesis is something really romantic rather than the practical aspect of doing it. So I would like to begin with Dr. Pravin Taware, who is from Mumbai. He has done his IP from Coimbatore and currently is attached with Gleneagles Hospital Parel and Group of TB Hospitals Mumbai. So welcome Pravin to today's webinar. I would like to welcome Dr. Swadip Mishra, who has done his DNB from Sir Gangaram Hospital, a very, very world-class hospital. And he has completed his EDRM, consultant pulmonologist currently at KIMS Medical College and Super Specialty Hospital, Bhubaneswar, Odisha. So welcome, Swadip. I hear it's very, very warm over there.
Yes, sir.
So braving the heat wave, you have come to our webinar. Thank you. Then we have Dr. Anish Choudhary with us, who is from Ranchi and who is a radiologist. He'll be enlightening us on the radiological aspects of thoracentesis, practical aspects, and he's also an expert at fluid मिल जाए तो Dr. Anish one is the one who will take it out for you. So welcome, Dr. Anish.
Thank you.
Then I have also to introduce one person who actually needs no introduction, Dr. Aditya Chawla, the he-man of IP nowadays in our country. So Aditya is from New Delhi. He is from whole of New Delhi, but specifically he is available at Jaipur Golden and Saroj Hospital. So welcome Aditya for today's discussion. Dr. Vinod, if you could just switch on your video for a moment, I would like to introduce you. Dr. Vinod Chauhan sir is there. Who is sir is also coming from Mumbai. So today we have two Mumbaikars and one guy from Delhi. All of the others are just chipping in, it seems. So Dr. Vinod Chauhan sir is currently doing practice at his own Chauhan Chest Clinic, and sir is also attached to Kokilaben Hospital, Navi Mumbai. So welcome, sir. It is a big privilege to have all this esteemed panel, and I would take this opportunity to introduce myself. I am Dr. Ravi Dosi. I am a chest physician from Indore, Madhya Pradesh. So now carrying on with today's order, one thing is very important that no pleural effusion should remain there if a person presents to you with a pleural effusion in sunrise with the sun up. Before sundown, the fluid has to be out. How it has to be out? How safely we can do it? What is there? Now I'll proceed with that. We have three very, very interesting presentations, which will be led by Dr. Pravin, who will be talking about pleural basics and thoracentesis procedure per se, followed by Dr. Anish, who will be very crisply enlightening us about the radiological aspects, and Dr. Aditya will be giving us a glimpse into the future and what our romanticized procedure of thoracentesis is now converting into and what the future beholds benefits for our patients. So now I would like to hand it over to Dr. Pravin for his presentation.
Thank you, CCI, for giving me the opportunity to talk. Thank you, Dr. Ravi, for the introduction. I'll be talking on pleural anatomy and thoracentesis. The What is pleura? Pleura is a serous membrane that folds back on itself to form a two-layered membranous pleural sac. The outer layer is called parietal pleura, which attaches to the chest wall, and the inner layer is called visceral pleura, which covers the lung. The visceral pleura is supplied with the bronchial circulation, and the parietal pleura by intercostal and internal thoracic arteries. The nerve supply of costal and cervical pleura is by intercostal nerves, and diaphragmatic pleura receives nerve from phrenic nerve, and visceral pleura from autonomic nervous system. That's why visceral pleura is not sensitive to the pain. When normally there is a small amount of pleural fluid found in the pleural cavity, which is 10 to 20 ml, which maintains the surface tension. When there is pathological collection of the pleural fluid more than 20 to 50 ml, it is called pleural effusion. Intercostal neuromuscular bundle, which is very important landmark in pleura, which lies along the lower edge of the rib, and the needle must be placed over the upper edge of the rib to avoid the damage to the neurovascular bundle. And always keep in mind, the liver and the spleen rise during exhalation and can go as high as 5th intercostal space on the right side and 9th intercostal space on the left side. So what is thoracentesis? It is also known as pleural tapping, needle thoracostomy, and needle decompression. It is a procedure that is performed to remove the fluid or air from the thoracic cavity for both diagnostic and therapeutic purposes. A cannula or a hollow needle is introduced into the thorax after administration of the local anesthesia. It can be done as a diagnostic procedure or a therapeutic procedure. A diagnostic pleural tapping is indicated for almost all the patients who have pleural fluid which is newer or uncertain etiology, more than or equal to 10 mm of pleural thickness on the imaging, and usually diagnostic pleural tapping is not indicated when etiology of the pleural fluid is apparent, as we see in a viral pleuritis and congestive heart failure. A therapeutic pleural tapping is mainly for larger pleural effusion when patient presents with significant symptoms like dyspnea and chest pain. If there is recurrent large pleural effusion, then we do therapeutic pleural tapping, and other options for recurrent large pleural effusion are intercostal drainage, indwelling pleural catheter, and pleurodesis. There are no absolute contraindication for pleural tapping, but there are some relative contraindications like bleeding disorder, altered chest wall anatomy, cellulitis of the chest wall, herpes zoster at the site of needle puncture, pulmonary disease severe enough to make complications like life-threatening, and uncontrolled coughing or uncooperative patients. So let's see step by step what is thoracentesis. Now, consent. Informed written consent is very important prior pleural tapping. Educate the patient and the family with the information such as how the procedure will be done, the procedure complications, benefits, and the post-procedure care. Consent is obtained from the patient or the family member. Also inform the chance of recurrence of the pleural effusion, and the patient should be told how to minimize the risk by proper positioning and the remaining still during the procedure. Step 1 will be arranging the equipments and materials and ultrasonography machine bedside. We need a local anesthetic around 10 to 15 ml of 1% lidocaine, a different gauges of needle from 22 to 25, 10 ml syringe, 20 and 50 ml Luer-Lock syringe for pleural aspiration, 3-way stopcock, antiseptic solution for dripping and cleansing, thoracentesis needle and the plastic catheter, dressing material, an appropriate container for the collection of the pleural fluid for different laboratory tests and microbiological evaluation, and ultrasonography machine. The positioning of the patient, which is a very important step, it is best done in a sitting upright position, leaning slightly forward with the arms supported. Recommend and supine thoracentesis as indicated in a ventilated patient, and lateral decubitus position during thoracoscopy. Bedside ultrasound of the chest is very important. Confirm the extent of the pleural effusion, and it is always mandatory to use ultrasonography bedside to minimize the risk of pneumothorax and increase the success of the procedure. Select a needle insertion point in the mid-scapular line at the upper border of the rib, 1 intercostal space below the top of the effusion, as we see in the picture. Draping and the cleansing in a sterile fashion, and always do it with antiseptic solution. Local anesthesia infiltration, which is very important step during pleural tapping. Always use 25 gauge needle place a good wheel of local anesthesia over the insertion point, then switch to the larger needle, which is around 20 gauge, and inject the anesthetic progressively deeper until reach the parietal pleura, which should be infiltrated the most because it is very pen sensitive, and continue advancing the needle until the pleural fluid is aspirated, and note the depth of the needle at which the pleural tapping is happening. Pleural fluid aspiration, as like when you do pleural tapping aspiration, use 16 to 19 gauge needle attached to the 3-way stopcock, and then to 50 ml or 20 ml syringe on one port of the stopcock and attach the drainage tubing to the other cock. Insert the needle along the upper border of the rib while aspirating and advance it into the effusion. When the fluid or the blood is aspirated, insert the catheter over the needle into the pleural space and withdraw the needle and leaving the catheter in the pleural space. While preparing to insert the catheter, cover the needle opening during inspiration to prevent the entry of air in the pleural space. Withdraw around 50 to 100 ml of the pleural fluid into the syringe and place the fluid in appropriate tubing and bottle for the testing. Large volume thoracentesis is indicated when you have a larger pleural effusion. Alternatively, you can aspirate the fluid using the syringe, taking care of periodically release pressure on the plunger. When large amount of fluid is withdrawn, monitor the patient's symptoms and the blood pressure and stop drainage if the patient develops chest pain and dyspnea. Coughing is normal and represents the lung expansion, and at the end of the procedure, remove the needle and catheter while the patient is holding the breath or exhaling. Post-thoracentesis care is also important. Always do chest x-ray or ultrasonographic screening after the procedure to exclude the pneumothorax. Analgesia if needed with NSAIDs, and tell the patient to report if any shortness of breath or the chest pain happens. Complications, the most common complication here is pneumothorax, bleeding when you hit the intercostal vessels, re-expansion pulmonary edema when you remove more than 2000 ml fluid in one shot, puncture of the spleen and the liver, vasovagal syncope, and adverse drug reaction to the local anesthetic drug which has been used. Why ultrasonography is mandatory? It gives a real-time guidance. It improves your safety. It reduces your complications like bleeding and pneumothorax. To summarize, make sure the adequate local anesthetic infiltration from skin to the pleura. Insert the needle just above the upper edge of the rib and not below the rib, and always do pleural tapping under ultrasonographic guidance. Thank you.
Good evening, friends. I thank Dr. Ravi for this invitation, and nice talk by Dr. Pravin. The topic of presentation today is imaging in pleural effusion, a radiological perspective. I would like to introduce myself. I am Dr. Anish Choudhary, consultant diagnostic and interventional radiologist. I am the director of Delhi Telerad and Delhi Diagnostics. We have 2 offices, one at Ranchi and one at New Delhi. So the evaluation of pleural effusion can be done via chest X-ray, ultrasound, HRCT, and MRI. The classic signs of pleural effusion, radiographic signs, include meniscus sign on frontal radiograph, detecting more than 200 ml of fluid, blunting of CP sulcus on lateral view, suggesting more than 50 ml fluid, subpulmonic effusion consisting of lateral displacement of the apex of the pseudodiaphragm. The CT signs includes sickle-shaped opacity in most dependent part of thorax and the posterior claustrophrenic sulci in supine patient, and fluid attenuation value of 0 to 20 Hounsfield units. These are some basic classical signs seen on chest X-ray, demarcated as the meniscus sign. When the patient is in upright, then when the X-ray is taken, the fluid will surround the lung base, becoming a meniscus, a concave line obscuring the claustrophrenic angle, and a part or all of the hemidiaphragm appearing hazy below. The CP angle blunting sign, blunting of the claustrophrenic angle in a chest radiograph is usually indicative of a small pleural effusion. It may be seen on either frontal or lateral erect projections. Approximately 200 ml of pleural fluid needs to be present for blunting of a costophrenic angle to be visible on a lateral chest radiograph. This is the lateral decubitus view. Lateral decubitus view with the dependent side down will demonstrate small amount of free flowing pleural fluid effusions. 1 mm thickness of pleural fluid in the lateral decubitus view is approximately equivalent to 20 ml of pleural fluid. The subpneumonic pleural effusion sign, in which they elevate the lung base on right side, and the difference of the stomach's shadow with the diaphragm on left suggests a subpulmonic effusion. The significant amount of pleural fluids can accumulate in subpulmonic regions as demarcated by the red line on the image, causing flattening and inversion of the hemidiaphragm without significant blunting of the lateral costophrenic angle. And in effect, the lung floats on a layer of fluid. This is again another case of subpulmonic effusion in which the frontal chest radiograph is showing the pseudodiaphragmatic surface lies more lateral than the expected location of the apex of an elevated hemidiaphragm. And we can see the non-visualization of intrapulmonary blood vessels below the right hemidiaphragm. On the right lateral decubitus view, it is showing fluid accumulations along the dependent hemithorax. The rock of Gibraltar sign demonstrates, it is seen basically in the lateral chest radiograph. It demonstrates the apex of the curvature of the lung base is shifted laterally, and its slope slants sharply towards the lateral costophrenic sulcus, appearing as a rock of Gibraltar's. Loculated effusion, incomplete margin sign. It occurs due to tumors, adhesions, and it appears as a homogenic mass with ill-defined superior border due to fluid dependency, true margins due to liquid content. Hence, the sign has got its name. The ultrasound appearance of pleural effusion appears as anechoic collection, and minimal collection can be seen. It is the most advanced investigations for detecting pleural collections, effusions. So most pleural effusion, whether free-flowing or loculated, are hypoechoic with a sharp echogenic line that delineates the visceral pleura and lung. See this line. An anechoic effusion can be transudate or exudate, but a complex septate, complex non-septated or homogeneously echogenic effusions are always exudates. Fibrinous septations are better visualized on ultrasound than on CT scan. Ultrasound has the added advantage of being portable, allowing bedside imaging with the patient in a sitting or recumbent position. So this is the descriptive image of a patient showing complex septated collection, and it came out to be an exudative pleural effusion. This is a displaced crux sign. Displaced crux sign in pleural effusion, in which CT scan reveals anterior and lateral displacement of right diaphragmatic crust by pleural fluid, which is depicted by the black arrow in a patient with bilateral effusion and ascites. Ascites does not extend below the bare area of the liver as seen in the white arrow. These are my references, and I thank you for a pleasant listening. And for any questions, suggestions, you can inquiry, you can contact me. Thank you, Chest Council of India, and thank you, the office bearers, for giving me this opportunity to be in front of you. Okay.
Good evening. Thank you, CCI, for giving me this opportunity to speak. And thank you, Dr. Anish, for such an elaborate presentation on ultrasound and X-rays of thoracentesis. Now I'm going to speak of future of thoracentesis, which we have been waiting. So we are going to talk about the overview of the future devices, the advantages, the disadvantages, the complications, and the different procedures which we are doing and which we are expecting to have in the future. So the future that is now is the IPC, which we are doing, and it has completely changed the management of the malignant pleural effusions, the recurrent pleural effusions, and it is effectively employed as first-line therapy in some malignant cases. So intermittent long-term drainage, the patients who need with recurrent pleural effusions, unresponsive malignant pleural effusions, or recurrent abdominal ascites, many cases of recurrent renal hepatic syndrome, and the patients not having pleurosis post injecting talc also, these cases require IPC placement. So the advantages are the IPC provides early discharge to the patient, minimal repeated admission of the patient, improving the quality of life, and improved control of the patient over his own disease, the discomfort and the breathlessness, and the cost overall is reduced because the frequent visits to the OPD, the frequent doing thoracentesis, that also puts a hole in the pocket of the patient. Complications are less. They have been reported around 2% in the literature, but still they are there. The pleural infection, catheter tract metastasis, loculations, severe chest pain, dislodgement and blockage, and these all are very easily managed, and we don't need to get scared of putting an IPC. So how do we do an IPC? First, we localize with an ultrasonographic guidance. Dr. Anish must be seeing the videos and he must be appreciating it. So we need to localize where to place the IPC first. The largest pocket we localize by the ultrasonographic guidance. Then we localize the intercostal space in which we have to place the IPC. We drape the patient. We practice all the aseptic techniques as a pleural procedure we do. Then we give the xylocaine, we infiltrate with xylocaine, and we place a guide wire catheter. We place a guide wire introducer with a syringe, and we remove the syringe and we introduce the guide wire. Now it's up to you. You want to make an incision first, you want to put the guide wire first. Although some anesthetists, they prefer to make put the guide wire first and do the incision later, but it is much convenient for us to put the incisions first and the guide wire later, because the guide wire gets in the way of doing the dissection. So after this, we localize the tunneling. We locally infiltrate the tunnel with the xylocaine. After that, we put a guide wire introducer, fill the syringe, we check the fluid is freely coming, and we leave the guide wire introducer in place, and we insert the guide wire inside, such that 2/3 of the guide wire is inside the pleural cavity. And after that, we remove the guide wire introducer and leave the guide wire in place. So after that, we attach the tunneler to the IPC, we insert it into the tunnel, we insert it to the second catheter site and get it out from the first incision site. So the second incision is our exit site. The other side it comes out. Then you detach the tunneler from the IPC. And we need to place the IPC in such a way that this polyester cuff, this polyester Dacron cuff, this comes beneath the skin around 2 centimeters away from the second incision site, which is going to keep it in place after the adhesions form. After that, this is the beautiful part. We insert the tear away catheter and the dilator into the pleural cavity after threading it on the guide wire. And when it is in place, we remove the trocar from it, and we ensure the free fluid coming. Post this, we insert the IPC in such a way that all the fenestrations disappear beneath the pleural cavity. And then, now look at this technique. We start tearing it away. So this is a technique of tearing it and pushing. So we tear and push, tear and push, and tear and push till this whole IPC, this reduces beneath the skin, and we cannot see the IPC outside the skin. And we should ensure that there is no kink remaining in the IPC, otherwise you need to convert it into an open thoracostomy. Suppose this, when you have done with the IPC, you attach with the vacuum bottle container, and this switch, this is a very unique switch. This is only active when you place it with the vacuum container or the matching pleural drainage switch, and it does not activate without any other modality. If you want to aspirate with a syringe also, it won't work. So it is only made for the unique switches in such a way that it is going to go only the drain is going to happen in the vacuum container only, or there is an alternative. By Rocket People, they are providing small attachment which is attachable to Euro bags. So this whole bottle system, this vacuum bottle, this comes out to be 2000 to 2500 per bottle, and this is only single use. So we use Euro bag instead, because in our place and in our country, the economical status is not very good of the patient. And even because the patient is also a case of malignancy, they say that how much you put in the money, nothing is going to come out. Then after that, when you're done with the IPC, you dress it, you drape it, and you're done. So this is the IPC set, as we told. Now, second is the Sildinger chest drainage sets. This is another technique of doing thoracentesis in which you are going to less harm the patient. We are going to take out the trocar, the harming thing of the catheter, and we drain the chest easily without injuring the pleura and causing pneumothorax. Another thing in the market, this is a medical thoracentesis catheter, 8 French catheter, in which this goes inside the pleural cavity. This is attached to the skin, and you can drain the fluid from this port, and this remains here. This is again the unique switch, and it gets closed. It only gets activated when a matching switch is placed with it. And when you see, this is very easily done. The pleural fluid can be removed very easily from this without injuring the lung, because the trocar is not there. This is a flexible silicone catheter. Another thing in the market, that is the 6 French catheter, the larger French catheter. This is also easier to place, and it helps to remove the fluid very easily without injuring the lung, less force required, and it can be left in situ for a maximum period of 30 days. So another alternative to IPC, another alternative to ICD, another alternative to so many things we can do. Ladder cath is also available, mainly done in CKD patients, because we need to evacuate fluid frequently from them. So that also can be left in situ for around 20 to 30 days. This is another system that is available, the pleural evac system, in which inbuilt suction is available, and we can remove the fluid as the fluid comes with setting on the meter gauge. We can set a flow and we can evacuate the fluid. Now this is a Himmlisch valve. This is mainly used in cases of pneumothorax, but BTS guidelines does mention them in the ambulatory domestic devices of uses in the thoracentesis. Patient gets relief by placing this also, and they can go home and they can evacuate their fluid themselves easily. And this is another alternative of IPC. So we can see this is the past, this was the present, and now is this the future, what we are talking about? or we have something in store for us. Thank you.
Wow. Thank you, Dr. Aditya, for really a very, very interesting talk and look into the future. Thanks to all the presenters. Well, CCI gives this platform to all of us so that we can discuss common topics regarding our day-to-day practice. So, although we are the panel which is sitting in front of everybody, but behind is a panel comprised of Dr. Krishna, Dr. CVK, Dr. Atri, Dr. Shivani, and Dr. Narayan Pradeep, who is always there. So they contribute so hugely to each and every topic that it becomes very comforting by the time we actually come for this panel discussion. So a big thanks to them for allowing this detailed discussion on thoracentesis to happen. Thoracentesis, past, present, and future. In our discussion, we have tried to cover the existing knowledge, and now we would take it forward and like to include all our stalwarts for more practical in knowledge and know-how as to how to go about it. So I would like to call in Dr. Swadip. Well, Dr. Swadip, tell me, what are the commonly encountered cases of or causes of pleural effusion that you see in your practice and subject them to thoracentesis?
Thank you, sir, for the question. In our practice, routinely we see tubercular effusion as the most common cause, TB being an endemic disease in this country. And that is if the effusion is exudative. But if we are suspecting transudative effusions, then in that case, your congestive heart failure cases, they are the most common. But then we always need to aspirate the fluid first, and after the analysis, only we can say whether it is an exudative or a transudative. And if it is an exudative, then our differentials go towards tuberculosis or malignancy or a parapneumonic effusion. And if it is transudative, then definitely it has to be either a cardiac cause, or there should be a liver cause or a kidney disease. But in general, if you say, then the most common would be tuberculosis.
Right. Right. No, I can't agree with you more. And definitely, whenever we come across a pleural effusion or even referred patients for pleural effusion, usually you see such a lot of cases who you just see a pleural effusion and are labeled as tuberculosis, even without thoracentesis. So, but definitely, subjecting to thoracentesis is important. So, Dr. Vinod, sir, I would like to call you in. If you could unmute yourself, please.
Good evening. Good evening.
Good evening, sir. Sir, like Dr. Swadip has told us what are the usual pleural effusion scenarios which we come across in our practice. So, suppose a patient of pleural effusion presents to you, then, sir, how would you work up this case, sir? How would you go about it?
Thank you, CCI, for giving opportunity. So, if any patient come to me for a effusion with the X-ray, so we are calling it as a pleural effusion on the basis of the X-ray. So, I will first go for the ultrasound of the chest to see the type or consistency and nature of the effusion, either it is unilateral or bilateral. And then accordingly, I'll place for the thoracentesis for tapping to rule out the etiological causes behind it. So first, most important, any effusion if you are planning to go ahead, must do the ultrasound of the chest for to move ahead.
Right. So, please go ahead, please.
Then accordingly, we will tap the fluid, and then we'll rule out the other causes. As Dr. Swadip mentioned, the most common cause in our India is the tuberculosis, but we have to look for the other causes also. So the thing is that we have to go for the ultrasound. That is the mandatory for doing anything further for the pleural effusion patient.
Right, sir. So radiology is where it all starts with, and definitely it is a very important part. But Dr. Pravin, one thing that just strikes our mind. At times we send patients or we go in and plan to do a thoracentesis. We often hear ki do a diagnostic tap, no do a therapeutic tap. So ye maya kya hai? When to do diagnostic, when to do therapeutic?
Yeah. Thank you, sir. This is a very important question, sir. Like as you see, routinely so many patients with pleural effusion. So here, this is we need to be very clear that we are not do a diagnostic tap or a therapeutic tap. So any patient, if you get a mild to moderate pleural effusion coming to you first time, any new undiagnosed pleural effusion, or if you see a pleural effusion thickness of more than 10 or equal to 10 mm, on imaging, maybe a USG or chest radiography. And when you need additional samples, when already patient is diagnosed pleural effusion, but you need additional sampling for further microbiological or any pathological diagnosis, then you can go ahead with the diagnostic pleural tap. Therapeutic pleural drainage can be simultaneously done with first diagnostic drainage procedure when you have a larger pleural effusion, or when patient is having a large pleural effusion and significant respiratory compromise in terms of dyspnea, chest pain, or hypoxia. And if the pleural effusion are recurrent or refilling, and when patient doesn't want any further interventions like intercostal drainage or indwelling pleural catheter or pleurodesis. Thoracentesis is usually not needed when the etiology of the pleural fluid is apparent or obvious, like in cases like we see cases like viral pleuritis, congestive heart failure patients, fluid overload in CKD, where a diagnosis is clear cut and we don't have any confusion in our mind. So we need to be very clear about diagnostic and therapeutic tapping. When you have a larger pleural effusion, at the same time of diagnostic tapping, you can extend it to the therapeutic tapping.
Right. Very eloquently answered. Just tell me, Pravin, one thing, that diagnostic tapping in ML, how much would you go for?
So routinely we aspirate around 50 to 100 ml of pleural fluid and make sure most of the pleural fluid will go for cytology when you are suspecting some malignancy. And rest of the fluid we divide for other microbiological and other laboratory tests.
So that means you presented in your video very beautifully the steps of thoracentesis, but equally important is that you need to keep such containers also, sterile containers for sending cultures, samples, and adequate bottle for sending that fluid of cytology to the pathologist. So that is also needs to be taken care of, because aap to needle pakad ke khade ho, the assistant, they also have to be knowing what all is needed and all. So now coming to a very important aspect which Krishna sir really wanted us to emphasize on, I am giving this question to Dr. Swadip. Dr. Swadip, tell me, आप कंसेंट तो लेते होंगे और आप प्री प्रोसीजर चीजों को चेक भी करते होंगे. Just tell me, before starting the thoracentesis, how do you convince the patient and what is the consent?
Thank you, sir. First, like when the patient comes to us, we explain to the patient exactly what is pleural effusion, what are they facing, the problem, where the fluid lies. Many times they think it is inside the lungs and mere lungs mein pani bhar gaya, mere lungs mein pani bhar gaya. So we try to explain that this is not a very emergency situation, but this needs to be evaluated because we need to find the underlying cause why you are having this fluid buildup. And then we explained in detail, like what is the procedure that we are going to do, the steps of the procedure, how during the procedure the patient should be very still, they should not move. This has been very well already explained by Dr. Pravin. So I'm just revising it. Then we need to tell the patient also about the complications that can arise if there is like leakage of air, or there could be bleeding, there could be hemothorax due to the bleeding. And most importantly, vasovagal attacks also happen in certain patients, which is an emergency situation. So these things we need to explain in detail to the patient in a language which they can understand. And after they give the consent, only we should proceed. Sir had told that there is no absolute contraindication for the procedure, but consent is always an absolute contraindication. So after the patient gives the consent, we should arrange all, like before going for the procedure, uh, the patient would be having an X-ray. We should always have an ultrasound. Without ultrasound, pleural procedure should not be attempted. And time and again, this has been emphasized in various forums that ultrasound guided pleural procedures are mandatory. So yes, consent. After explaining everything in detail, we should obtain the consent, and most importantly, the consent should be taken on the day of the procedure and not previously, because many a times what happens is just before the procedure, seeing the needles and all the arrangements that we are doing, the patients become apprehensive. कि नहीं डॉक्टर साहब नहीं कराना है अभी नहीं कराना है so the consent should be taken just before the procedure, forced upon the patient. It should be from the role well.
Right. And do you check certain things that कि यार ये तो होना ही चाहिए, like you mentioned an X-ray, you mentioned sonography, you mentioned consent, but
Yes, sir.
I think even we should check all the instruments that we might need at that point.
Definitely, sir.
Right.
Definitely, sir. So we firstly we need to see the patient's profile, whether they have any coagulopathies or they're on any medications that can cause a bleeding issue. Then when we are arranging the things, first of all, ultrasound should always be with us. Then we should have a sterile environment and proper positioning of the patient should be there. And our thoracentesis kit, that we should have a thoracentesis kit which should have the adequate size of needles that we will be using for the procedure, and syringe and sterile containers, as sir had said, sterile containers for your microbiological analysis. And based on that, if we should always keep it prepared beforehand, because during the procedure, once we are inside the pleural cavity, we cannot be moving around, like we cannot move, but we cannot also ask people, "Arey, ye nahi hai, ye le aao, wo nahi hai, wo le aao." So before that, we should have a list, a checklist kind of a thing, and we should follow that before starting the procedure.
Right. So, but I agree with this thoracoscopic kit, this thoracentesis kit that you have told about. It's good. And I think, like, we order in ICU or OT, ICD tray le aiye, ya fir CVP tray le aiye. Same thing, we should give and plan for a proper thoracentesis kit. But tell me one thing, Swadip, in Bhubaneswar or maybe wherever our colleagues are practicing, what is the place that you would recommend for tapping? Can we just tap anywhere?
Sir, ideally, we should have another separate treatment room, isolated away from the wards and like I'm talking about the wards and the ICU. Obviously, we can't shift the patient. Sterile environment is absolutely necessary because we might convert a normal transurative pleural effusion into an empyema if we do not follow proper aseptic procedures. So a separate treatment room with sterile environment is absolutely necessary, and it should be away from the other people and not in the middle of the ward where people are around and the patient gets apprehensive. Okay, why is everyone staring at me and what is happening to me? So yes, a separate treatment room should be.
Tell me one thing, nowadays we have monitors available. So do you connect a monitor to your patient when you're tapping?
Yes, sir. When we always have the patient saturation probe, pulse rate should always be monitored, and we also give oxygen to the patient while doing the procedure, and a low flow oxygen, just so that the patient feels relaxed and is less apprehensive that something is happening to him.
Right. No, very well answered. You gave a very good introduction to how, there is one concept called as a pleural clinic. So if somebody really wants to open a pleural clinic, then I think Dr. Swadip's talk, you should hear again and again. And my other colleagues will also be talking about it. And you can always visit this webinar again because it will be uploaded on CCI's official YouTube channel, which is really a great knowledge bank of chest in a few days' time. So one thing कि चलो यार अब डिग्री आ गई, क्लिनिक खोल दिया, प्लूरल क्लिनिक खोलेंगे, प्लूरल क्लिनिक खोली, सब कर दिया, सोनोग्राफी मशीन ले आए. सोनोग्राफी मशीन ले आए, काम चालू किया और नोटिस आ गया कि भैया पीसीपीएनडीटी का क्या. सो
रवि सर, इससे पहले एक चीज मैं बोलना चाहूंगा. There was a case, a patient was a case of massive proliferation, maybe in Bombay. Patient was stabbed by a critical care specialist and he had gone into the expansion pulmonary edema. Patient died. So there was a case on the critical care specialist. His degree was snatched away by the medical council board, and that case had happened in the triage area, the emergency area. So that case pivoted on the same topic, that why did you do it in a triage area? Why didn't you take help of a ultrasonologist? And why did you tap the whole of the fluid? So as Swadip said, कि plural clinic होना चाहिए, there should be a safe area, and these kind of things, you never know when they backfire.
I fully agree with you. Nowadays, like I have seen people with 2-room OPDs also in the back room tapping fluids just like that. It's actually risky business. And if you want to go by how we should, then we should do all things under proper.
We can also do pleural manometry. Manometry में अपन अगर -20 से नीचे जाएंगे तो फिर the patient may suffer re-expansion pulmonary edema. So we need to keep it up.
Yes, no, definitely very relevant, and we will be discussing about that topic also up ahead. So, what I was building up to is there is something called as PCPNDT, and we are lucky to have an expert on PCPNDT in our panel. So, Dr. Anish, I would like to call you in on the discussion, and like of course, my chest related question to you would be regarding my positioning and marking and all the things that we expect from you. But more importantly, so we all would like to understand that does USG chest have any relation to this PCPNDT Act?
Yes, it does has a relation to the PCPNDT Act. According to the provisions of the PCPNDT Act, no one in India could own an ultrasound machine without getting the machine registered under the PCPNDT Act to the district appropriate authority, which is CMO in many a case, or the district magistrate of the district. So prior obtaining or buying ultrasound machine, you have to submit Form A to the PCPNDT authority and the relevant security deposit, and you have to specify either for what the purpose of the obtaining the license to operate. It is given for 5 years, and every 5 years it is renewed. You have to district to district it varies the requirements, that they need a room, a bathroom, a uh, proper setup, and most important thing that you have to give in declaration that you will not be using the machine for any kind of preconception or prenatal sex determination. So you will be using it for the just for your diagnostic purpose, that to consider to your area of the that you will be using for the lung ultrasound, that you have to specify that. And also on monthly basis you have to maintain a register, a PNDT register, in which you have to every month mark it 0, that no pregnant female ultrasound has been done, and same has to be typed on a letterhead and submitted before 5th of every month to the PCPNDT authority in order to be legally safe.
Safe. Yeah. Very important, because you might take a consent, you might do everything, but these are some such realities of practicing and managing things that we should very well be aware of them. Like Dr. Swadip mentioned about the consent, and Dr. Anish talked about PCPNDT. These two things, please keep yourself updated and aware. So thank you, Dr. Anish, for enlightening us on the legal aspects of pleural thoracentesis and sonography. But as a radiologist, I would like to tap your knowledge on telling us, we all the esteemed pulmonologists told ki the checklist most important thing is pre-procedure imaging. So what are your views about pre-procedure imaging as regard to thoracentesis? And we often refer to you for marking the position where we should put in the needle. So could you please enlighten us on these things?
See, whatever till now in this seminar I have listened to is most relevant. You people have very beautifully depicted that the positions to be taken, like the sitting position or when well ventilated, the lying down or recumbent position, and we have to choose the maximum depth of the pleural fluid, and we have to use the upper border of the rib, and we have to go a little up to the pleural effusion marking. So all of these things are all same. Where the difference lies using a radiologist, that we are well equipped with the needle position and the probe position, because we are doing it on a day-to-day basis much frequently. So we know, okay, the needle, where my needle will be inside and where the probe is. So that a little upon practice, most of you will master that skill. So it is nothing like a radiological perspective. It is just that we have to be well acclaimed with our needle, where it is going, एंड सीइंग द पेशेंट कंडीशन साइमल्टेनियसली, कि कहीं कोई नर्व को तो नहीं हिला रहा, ठीक है, अपर बॉर्डर भी अगर यूज कर रहा तो कोई नर्व तो नहीं हिला रहा, पेशेंट तो नहीं काम है कि या नहीं है। उसको पहले अगर हम लोगों ने व्हील बना दिया लोकल एनेस्थेटिक का, तो एक टेस्ट पंचर करके देखिए, पूछना है पेशेंट से, दर्द तो नहीं हो रहा बाबा, या दर्द तो नहीं हो रहा माता जी, एंड देन एडवांस, देन it will be a win-win situation for both of the patient also and for you also, and you will do it successfully.
Right. Now, just tell me, Dr. Anish, that you very well told कि यार दर्द तो नहीं हो रहा माता जी, but sometimes 90 kg माता जी comes and it becomes very difficult for us. How do you manage these 90 kg माता जीs?
The thing is that then what we have to do, that we have to stretch it. Most of the time, what I do, I stretch the skin lining, the subcutaneous fat lining, and then ask my attendants to keep it like that, and then we do it.
Right. And needles usually, these patients require longer needles. Like Swadip's kit should also have, long LP needles at times.
Yes, LP needle is very helpful in deep-seated effusions.
Very helpful. So, अब needles की बात हो गई, किट की बात हो गई, पीसीपीएनटी की बात हो गई, तो दर्द तो हो ही रहा है सभी को कहीं ना कहीं। उस दर्द को मिटाने के लिए आदित्य भाई, आप हमको बताओ यार, लोकल एनेस्थीसिया क्या देना है इस टैपिंग के पहले?
Sir, basically injection lignocaine 1% should be used. It should be diluted. That is 1% we are using. First, we infiltrate with a small needle. We raise a wheel. We raise a bleb, and then we proceed further. We need to anesthetize the subcutaneous tissue. We need to anesthetize the percutaneous, the periosteum, and we need to anesthetize the pleura, because this is the most painful part of the skin of the pleural tapping. When we do the tapping, it is the most painful procedure if we don't do it. And sorry to say, when we see in government hospitals, people are not using xylocaine. They are tapping the patient as it is on the bed only. So xylocaine is very necessary. Why to put the patient through a pain which is not required?
Right. So a simple lignocaine 1% usually suffices. I agree. And suppose you have tapped out, like we had discussed regarding therapeutic tapping. So post procedure, what are the things that you would like to monitor?
So post procedure, if you have just tapped normally, the fluid has been tapped out and there was no complication, there were no repeated insertion of the needle and repeated pricks of the needle, you don't need to get an X-ray post therapeutic pleural aspiration. Once you aspirate a chink of air, or you had to do multiple pricks in that patient, you need to get an X-ray done, that whether you have injured the pleura or not.
Right. So post-procedure X-ray is the most important advice. And
correct.
Like, suppose Aditya, you have trapped a patient, removed a significant fluid amount, maybe 900 ml or 1.5 liters. So subsequently, what would you recommend? We can just let that patient go, or we need to monitor them a bit extra?
No, we need to monitor the patient for next 20 minutes to 1 hour. We need to keep the patient in our place only. We need to put the monitor on. We need to check the vitals of the patient after every 15-20 minutes. BP check kare patient ka, so that we know that patient is not going into any shock or vasovagal or these kind of things which we observe post tapping in in very less of the patients.
Very less, right? Quite right. So luckily, thoracentesis, though such a very important procedure, but relatively post-procedure patients are event-free. If we have taken care of all the things before, then afterwards will definitely be much smoother. Dr. Vinod sir, I would like to know from you that is there any contraindication for thoracentesis?
Uh, there are very few contraindications for thoracentesis, like if the fluid is insufficient, if the depth of the fluid on sonography is less than 1 centimeter, it has to be more than 1 centimeter to tap the fluid. Any kind of skin infection locally when we enter our needles, and the condition, bleeding disorder or bleeding diseases, like if it is the INR is more than 2, if the platelet count is less than 50,000, and if the high creatinine, these are the very few contraindication to tap the fluid. And in any history of any kind of complication happened in the past for the pleural tapping in the same patient, that can be the contraindication. So there is no much contraindication in the for tapping, for pleural tapping.
Okay. Now, but one thing, in our discussion, one thing came across as a relative contraindication or something to be careful about is a coagulopathy. So, Dr. Vinod sir, suppose a patient is sick in the ICU and he is having a deranged coagulation profile. Then what would you tell that what precaution or how do we go about it?
Then we have to just means there is a not much if we go with the ultrasound guided, there is a very minimal chances. Then we can wait for the correction of the coagulopathy, and if there is a urgent need of the pleural fluid tapping, then we can go with the some correction of the coagulopathy, and we can do in an emergency basis. But if the procedure needs, we can go ahead.
Right. So some things generally which we see in which procedure is delayed, like when there is a less than 50,000 platelet count, or when the INR is more than 2, or like Dr. Swadip has mentioned, if the patient is on some higher dose of anticoagulation, then we have to be a bit careful. We have to delay it if it is something which is avoidable. But if it is mandatory, then collection of platelets and INR using transfusions is indicated. So
Yes,
I
sir.
know of people कि वो भैया FFP ongoing रहेगा तभी टैपिंग करेंगे ताकि रिस्क एकदम कम रहे, वो पहले भी देना नहीं पसंद करते. So this is something which is a very common sight in the ICU कि सुबह 9 बजे के राउंड में बोल के जाओ हो जाएगा और रात को हो रहा है 6 बजे when the FFP is arranged.
So we need to weigh the benefit and risk ratio of the patient and the procedure, and we need to proceed.
We need to definitely.
Yes, definitely.
Yes, definitely. So tell me one thing, Vinod sir, आपको मैं छोड़ूंगा नहीं, एक बात मुझे और बताओ कि यार ये ICD भी है, तो अब thoracentesis छोड़ के ICD पे कब जाए?
Sir, if the any effusion that is recurrent pleural effusion, we can go think of the ICD, but later we can think of the IPC also. And if the effusion is complicated like empyema or pneumonic effusion, parapneumonic effusion, that is empyema or loculated effusion, on aspiration, if we are seeing that is a pulse-like structure coming, then we can think think to go ahead with the direct ICD if the patient is septic, and on aspiration we are not finding the clear fluid. So the most common indication for ICD is pneumonic effusion, empyema, loculated effusion, patient who is not responding to antibiotic, and that the other causes are not there. So we have to just put the ICD to drain maximum fluid. We have to just remove the septic foci. And any parapneumonic effusion that is not responding to the antibiotic, we have to drain it out. And then other case in traumatic condition or trauma, if there is a hemothorax, we have to remove that blood rather than the tapping. So in that case, we need a urgent ICD.
Right. I agree with you. When the fluid is a relatively higher pathological fluid, blood or pus, then ICD is more justified than going for thoracentesis. But Aditya, you in the future of our thoracentesis lecture, you had taught us about indwelling pleural catheter or IPC. So, now this IPC has come up twice or thrice in our discussion, and I also like to apprise you of one question from Jammu and Kashmir by Dr. Naeem, who asks us ki the CKD people with recurrent fluid collection on maintenance dialysis in limited areas, in areas with limited facilities. For all of this, is IPC the solution, or how do we go about these managing these cases?
So that is the beauty of IPC. IPC is indicated in the patients who have recurrent filling. The patients who require intermittent drainage at a regular interval with recurrent filling, these are the patients for IPC. Now he's talking about the dialysis patients, the patients who are having recurrent pleural effusions, and we need to do the thoracentesis repeatedly on these patients. So IPC is the solution for these patients, and we personally, I am having very good results in CKD patients. They do very well because when this fluid problem is handled, so they are well off from one side. Then they can proceed with the dialysis. They are comfortable with their evacuation of the pleural cavity on their own terms. So that is how the IPC gives the control of the disease to the patient himself, and they can evacuate the fluid as and when they are required to, when they feel the symptoms, or if they want an autopleurosis to occur. So we advise them to do it drain and the drainage daily or on a 1 day leave and 1 day alternate day basis.
Right. So, like one condition came out as CKD. So, any other indications for ICD? Any particular indications, or just
so patients with recurrent pleural effusions, malignant pleural effusions, then patients who are having failed pleurodesis, those kind of patients, then with the patients of trapped lung and having those fluid, the fluid inside the pleural cavity, those are the kind of patients which have IPC as an indication, and the patient benefit very greatly from the IPC.
Right. So, चलो मान लिया आपकी बात, आदित्य ने मैं कन्विंस कर दिया कि डाल दो. अब when to remove it? इसको रिमूवल के भी कोई क्राइटेरिया है क्या?
Removal का criteria ये sir, that the patient is suffering from the IPC first, or the patient has got a autopleurosis and the pleural fluid is not forming anymore. Then the patient has an infection and pain and locally and the IPC is blocked. Those are the only indications the IPC needs to be removed. Otherwise, IPC can be kept in place for years together. It is made like that it should not be removed.
Right. That's a very big statement. See, years together you keep an IPC. But Pravin, tell me, यार years together बोलना आसान है. ये तो बताओ कि what care आपको बोलना क्या है patient को? What care do you take when the IPC is in situ? How do you counsel the patient?
Yeah, it's very important when you have any catheter inside, maybe it is intercostal drainage or indwelling pleural catheter. You need to understand here, you'll have to, as a physician, you'll have to take care of IPC, and as a patient and family, you need to educate them and train them about the IPC, how it functions, and always train them about how to use those vacuum bottles when necessary to drain the pleural fluid at home. And the changing the dressing is also very important when patient is having IPC for months together. The changing the dressing at least once a week is mandatory. Always wash your hands. Tell patient wash your hands well before and after the drainage, and handle the catheter with the gloves always, making sure the catheter is always clean, covered when you are not draining the fluid. Avoid going to swimming pools and don't take bath in hot tubs, like small things but very important. And always whenever he drains at home, always tell him to check for any signs of local infection, or any signs of infections like fever, pain, redness, and whether catheter is blocked or not. And always report to your doctor. This is very important when you put IPC, and always tell them in advance. And whenever that patient comes to you in your clinic, always remove the dressing, check any signs of cellulitis or any skin infection, and then accordingly act.
Right. So you immediately you evoke the interest of the audience, and Dr. Sushma Dugat from Maharashtra Nashik is asking ki what are the chances of the blockage of your IPC? Pravin?
Yeah, so it can happen when you have very fibrinous pleural effusion, sometimes seen in malignant pleural effusions. So a blockage is seen. Like we have around 21 cases where we have seen blockage in 2 patients. So it is seen, and it is due to fibrinous exudative inside the pleural fluid, and it can be managed. It's not like you cannot manage or you have to remove that catheter. It can be managed just by flushing the normal saline at very aseptic technique.
राइट सो एक चलो कॉम्प्लिकेशन बताओ मेरे को. एक कॉम्प्लिकेशन तो हो गया ब्लॉकेज, और क्या क्या है?
Yeah, so most commonly what we have seen is a local infection. So and catheter related infection, they are usually mild. Sometimes it can be like only cellulitis at the site of insertion. Sometimes it can present as an empyema, and sometimes only a tunnel infection can be seen. So you don't have to remove that IPC. You just have to treat with appropriate antibiotic therapy alone. And other complications, as Dr. Aditya had mentioned, seeding of catheter, the metastasis of the catheter site. Then sometimes loculations can form when you are having a malignant pleural effusion or parapneumonic effusion, or when you have CKD patients, you can see a lot of loculations when you put IPC and keep it for many days. Chest pain, it is like if you compare with ICD, the tolerance of the patient is very good with IPC, but chest pain can be seen in some patient post IPC insertion for 2 to 3 days. So you might have to give like analgesics for a couple of days. And dislodgement, yeah, Dr. Aditya wants
नहीं,
to
बोलो प्रवीण सर, आप पहले बोलो फिर मैं.
Yeah, and catheter fracture, it's not commonly seen, but if you try to remove IPC, which is which is there inside since many months or many days, try to remove a fibrosis adherent to cuff first and then remove. These are the main complications what we have seen, and sometimes pericatheter leakage. So that's why you'll have to check always the dressing whenever patient comes to you, and change the dressing.
So I would like to add 2 complications that have been seen in the later times are: one, the cuff is getting detached from the IPC and being left inside. So detachment of the cuff from the IPC comes out, the IPC cuff remains inside. So we need to dissect it carefully. Better
Right.
we do it the blunt dissection in a specific manner. And second thing that Dr. Pravin said, this dislodgement. Now a question comes into the mind: when the catheter has been tunneled and then put into the pleura, why is it getting dislodged? So the patient who are on chemotherapy, they tend to lose a loss of muscle, a very loss of muscle weight is there, right? Very high loss of muscle weight is there. That is why the cachexic patient which we get post chemotherapy, the weight loss that occurs, that causes this hinge to get loosened up, and that is why they get dislodged. So we need to keep on checking that the IPC is in place, the stitches are in place, they don't get loose, because dhire dhire this turgosity of the skin that gets loosened up post chemotherapy.
Definitely. So
Right.
one thing is there that the dictum goes now, the more machinery, the more the complexity and technicality.
Correct.
So thoracentesis is very simple, very easy to do, but IPC, although much more convenient in the long run, but still it has to be handled with care. So IPC is an excellent, I would say, future prospect, or even now, what even future? Now it is very common. Every
We are doing right.
we should go in for putting IPCs in these cases. But now we have done the mechanical part. Now tell me, Swadip, I would like to call you in again, that what are the commonly ordered pleural fluid investigations once you have put in an IPC or you have drained it? So what do you order? What are the relevant things?
Sir, when we take the fluid, firstly, we have to know whether it's a transudate or an exudate as per the lights criteria. So we send it for our normal protein, LDH, and then we send it for glucose, ADA. These are in the biochemistry we send. Then we send a total cell count to know, and with the differential, of course, total cell count with the differential. Then we send it for microbiological analysis as well. See if the fluid is clear and straw colored, it is unlikely that it has a bacterial infection. But we should always be safe. And if we are doing a procedure, we should investigate for other causes as well. So we should send it for culture sensitivity. We should send it for AFB staining. And although the sensitivity is pretty low, we still prefer to send it for NAT test for tuberculosis. And cytology and cell block, definitely. Cytology should be sent for all cases. And cell block, if you are suspecting malignancy, so send at least 50 to 60 ml to the pathologist so that they can form a cell block and do further analysis if required. ADA is very important. Like I've seen many, like no offense meant to anyone, but I've seen many non-pulmonologists who do a pleural fluid aspiration. They just follow the lights criteria and they do not send it for an ADA analysis. And sometimes patients come to us. When they come to us, the pleura is already thickened and it is difficult to aspirate again. They have effusion, but we are unable to tap and get another sample to go for an ADA analysis. So had it been done in the first setting itself, then we would have had a clearer picture of where we are heading to and what is the differential in this patient. So yes, these are the investigations, basic investigations we should send. And then again, depending on the clinical picture, we can always send like if the fluid is very turbid, it's milky white. If it is milky white, then we can suspect it's a chylothorax. So we should send it for triglycerides and chylomicron. Then if it is very high colored or hemorrhagic, then to differentiate whether it is a hemorrhagic fluid effusion or it is a hemothorax, which we have done, or it's because of a trauma patient, whatever. So we should send it for hematocrit so that we can have a ratio like pleural fluid by serum hematocrit should be, if it is more than zero 0.5, then we will suspect that it is a hemothorax. So these are certain cases, like things we send. Books say that we should always send a pH, pleural fluid for pH. But in my center, they don't allow the pleural fluid to be used in the ABG analyzer. They say it will calibration gadbad ho jayega, aap pleural fluid mat bhejo. So yeah, that is something which we are unable to use it. But the rest of it, yes, we should always send basic investigations.
Right. So, Swadip, Dr. Ajay Lanjewar sir from Nagpur, he has asked some questions pertaining to your description just now. Sir asks us that what is the role of heparin or EDTA if we want to get a good report from a hemorrhagic fluid? Any suggestions from the panel? Dr. Swadip, would you like to comment on it?
Sir, it is in my routine practice that whenever I'm taking a fluid for cytology cell block, I do add heparin to it. What that does is it prevents the clot formation and like the cell structure remains intact. So suppose it is normally malignant effusions are very high colored or hemorrhagic. So adding heparin to it prevents the coagulation, the clot formation, and the cell structures are preserved. So it becomes easier for the pathologist to observe the cells and report.
Right. And anything else from the panel? Aditya, Vinod sir, do you use, Pravin, do you use heparin or EDTA in your common hemorrhagic effusions?
EDTA is a common practice we have noted, but I don't think I've sent it recently because hemorrhagic pleural effusion I didn't encounter last around 1 year. If a patient has high erythrocyte count, it is indicative of hemorrhagic pleural effusion, right?
So, Swadip, you told that you practice this. So, how much heparin, matlab, do we add? Matlab, any broad guideline can you give?
Sir, just 1 ml of
1 ml
heparin. Yes, sir,
suffices
1 ml.
usually.
Yes.
So, one more thing that Dr. Lanjevar sir from Professor Lanjevar sir from Nagpur is asking is that साइटोलॉजी सेल ब्लॉक की बात करी तो आपने क्वांटिटी 50 to 60 ml बताई. सर इज
Sir.
आस्किंग 1000 ml तो नहीं भेजना भाई, पूरा तो नहीं भेजना है क्या?
Sir, as for the discussion with the pathologist, they need at least 50 ml for a good analysis. बट अगर आपके पास 1000 ml है तो आप बेशक उनके पास भेज सकते हैं, बट देन वो गाली तो देंगे पैथोलॉजिस्ट कि इतना फ्लूइड क्यों भेज दिया.
That is a fact, you know. The same thing in our case also. They literally tell us ki why are you sending us these buckets full of water? Well, just 50 to 100 ml is usually, matlab even right, you're correct, 50-60 ml is what usually suffices. But definitely, the more that you send is always better. So,
But one thing rightly pointed by Sudeep, patients who are having thoracentesis done by non-pulmonary doctors, they are not sending the essential investigations. Maybe my LDH, I am not very fond of doing LDH. I send AD, I send cytology, I send biochemistry. And pre this thoracentesis, we have all the investigations done of the patient. So we know the kidney status, we know the patient's heart status, we know the patient's hepatic status, and we proceed. So we know what is the expected outcome we are going to have. तो LDH हाँ मैं नहीं भेजता हूँ, but it should be sent. But basically ADA, cytology and biochemistry should be done of every patient. May you not send it for gene expert, may you not send it for malignant cells, may you not send it for culture and those kind of things, because gene expert, I think it is only 15% sensitivity that is present in the literature. But ADA, cytology and biochemistry are a must. Non-pulmonary doctors should also send it for that, because uske baad jab time gaya and that patient, that pleural thickening has occurred, that is very painful for us also.
Right, quite right. So we need to have a consensus. एक mandatory हमको कुछ investigations send करनी है, and we should try to make it our practice and create awareness about that. अब IPL हैदराबाद जीतेगा, चेन्नई जीतेगा या कौन जीतेगा ये तो मैं नहीं कह सकता, राजस्थान जीतेगा. पर एक बात जरूर है कि लाइट्स क्राइटेरिया जब तक थोरेसेंटेसिस और प्लूरल एफ्यूजन की बात होगी उसके बारे में अपने को
हमेशा रहेगा, करनी है.
प्रवीण भाई, अब ये बताओ कि यार ये हाउ टू डिफरेंशिएट ट्रांसुडेटर एंड एक्सुडेटर.
Yeah, as you rightly said, last like it's more than 4 decades we have been using lights criteria, and it is very helpful. As we see in peripheries, we don't have all these fancy investigations. When you do only these 3 things which are mentioned in lights criteria, like if you are suspecting exudate and exudative pleural effusion, and when a pleural fluid and serum a protein ratio is more than 0.5, and serum and pleural fluid and serum LDH ratio is more than 0.6, and pleural fluid LDH is more than 2/3 of upper limit of serum LDH, you can label this patient as having exudative pleural effusion. And your proteins are very important. When you total pleural proteins are more than 30 grams per liter, you can label this patient as having exudative pleural effusion. And if one of these only one of these criteria is there, then you even if when you have confusion in mind, then you can do a albumin gradient, a pleural fluid and serum albumin, and that if that gradient is more than 1.2 grams liter, that indicates the effusion is transudative. So this is modification in lights criteria. And even though if sometimes even this lights criteria in around 25% of patients, when you have transudative pleural effusion, but it can show as a exudative, like you see in CKD patients or patients on hemodialysis, they are on diuretics. So in around 20 to 25% of transudative effusion can present as an exudative effusion. Here then you have other gradients like albumin gradient or protein gradient, and sometimes even if you are confused, then you can go for like NT-proBNP if you are suspecting a cardiac failure. These are the extra investigation you can send if you wanna do further investigations.
Right, quite right. And most beauty of this was, matlab, this Lights criteria was made when Mr. Light was a resident. So some things which we do in our residency, पूरी जिंदगी पूरी दुनिया को काम आती है. So that is why we have to enjoy our residency to the full. So Aditya bhai, this pleural fluid, everybody is telling us कि इसका total differential करा लें. So what do you see in this total differential basically?
So when we observe these all investigations we have sent, the biochemistry, then the cytology. Cytology means if it is lymphocytic predominant, it is an exudate. If it is polymorphonuclear predominant, it is an transudate. Then if the patient is having high ADA and low lymphocyte predominant, it is infective. Then there are lots of permutation combination. The patient is having sugar around 8 or 10, that is less than 40. Still the ADA is coming around 8 or 7.9, 7.4, 7.5. Now, these are the points where you can have a false ADA presentation because sugar less than 40 is an empyema. But when it is the pH is coming out more than 7.4, so there is somewhere there is having a false negative ADA which is being projected, and it may be due to the presence of some air, or there may be some presence of the blood in the syringe which you have sent.
Right, quite right. And at times, you even get interesting things when you get eosinophilia in your pleural fluid. Then that times also you need to suspect tuberculosis,
Strauss syndrome, tuberculosis, right?
syndrome,
Hypereosinophilic syndrome. Right.
hypereosinophilic syndromes, and at times lymphocytosis in young females. Lymphoma becomes a strong point that you can convince them to go for further investigations.
Correct.
So Vinod sir, tell me, this ADA is something which is very important. Dr. Swadip and Dr. Aditya are continuously promoting use of ADA for non-pulmonary physicians कि भाई करो ADA. तो विनोद सर बताओ ये ADA की क्या माया है?
Sir, as you mentioned, something you have to learn in residency that will go long. So I learned to write ADA first. Any typing I used to write ADA, routine cytology, and then like LDH, Arabic culture, TB culture, gene expert, and cell block. So ADA come first. So if the patient clinical history is suspicious of tuberculosis, and if your ADA comes positive, you can start the anti-TB treatment for that patient. But if in some case ADA can be positive in some malignancy, rheumatic lung disease, lymphoma, and other condition also like empyema, if the value is too high, then we can consider the other causes. If the value is above 40 up to 70, that is the indicative of the tuberculosis. If it goes high, then there is a suspicious of other causes. And if the clinical history is not suspicious of tuberculosis, you have to find out. Like Dr. Pravin and Chawla sir mentioned, Swadip sir mentioned, the routine is the criteria in the routine has to go toward the exudative fluid. Then cytology has to show no malignant cell. The other things like Aditya sir mentioned, that gene expert in the pleural fluid is very less sensitive, but the gene expert ultra shows some more promising result than the TB gene expert. But ADA has the most important factor in the clinical practice, not because we are working in the metro cities, so things are available easily. But in a basic setting, people are doing only the tapping and with the ATA routine and cytology, so that is helping. So if there is no other causes, you are not able to find the other causes. Yes, ADA is most important for the treating the TB patient in the rural side. It's like a AB smear in the pleural fluid. So even though if ADA is negative less than 40, that and the clinical condition, clinical history of the patient is suspicious of the tuberculosis, in the metro cities, in the big hospital, we can go for the pleural biopsy and a multiple test. But yes, clinically we have to rely on the ADA only. The thing is that when they tap, how much time to take to do the analysis, because many people does the tapping and send the fluid after 1 or 2 days. Many lab are not running ADA level on the daily basis. So ADA has to analyze on the day of the tapping, because some of the lab are not doing on routinely, they are doing twice or once a week. So that ADA, even though AD patient is tuberculosis, sometimes ADA negative can be because of the some lab issues.
Right, right. So, and I fully agree with you. This last point which you raised कि कई बार TND आपके सेंटर पे हो जाता है और ADA साहब हमने आउटसोर्स किया है, वो 4 दिन बाद आएगा. तो वो क्या आएगा 4 दिन बाद और किसकी हेल्प करेगा, दैट गॉड ओनली नोस. बट दैट इज वेरी इंपॉर्टेंट कि सेम डे मिलना और उसकी क्लिनिकल सेटिंग वी शुड अंडरस्टैंड, दैट इज वेरी इंपॉर्टेंट. इवन आई हैव सीन सीरम ADA and on basis of serum ADA they are making big decisions, although it is a questionable test. But still, time is running short and there is a lot to discuss. Tell me, Pravin, how we had come across chylothorax. Swadip had mentioned that. How do you diagnose chylothorax on thoracentesis?
Yeah. So basically, when you are like suspecting the chylothorax, your pre-diagnostic probability matters. When you have a post-surgical patient, some lymphoma case operated, and there is a lymph node resections, and then you can suspect a chylothorax when patient is having unilateral or sometimes bilateral pleural effusion. And when you tap the fluid, and if you see white milky fluid, then you always suspect chylothorax. Obviously, you can see milky fluid in a chronic pleural infection also sometimes. And even in absence of milky fluid, still there is a chance of chylothorax. So even if you see clear fluid, serous fluid, or serosanguinous fluid, that doesn't mean that patient won't have chylothorax. So it doesn't exclude the chylothorax diagnosis. So, and it is when you see this milky fluid coming out, you will have to send a pleural fluid triglyceride, and it should be done by lipid electrophoresis method, and it should be more than 110 milligram per dl, mandatory. But about 10 to 15% of patients, you might not see these values. You might see all pleural fluid triglyceride being less than 100, less than 110 also sometimes. That depends on the time of last meal. That depends on the what you have eaten in the diet, how much was the content, fat content of your diet. So it depends on so many things. And when you see such fluid, milky fluid, you need to send pleural fluid cholesterol, and pleural fluid cholesterol should be less than 200 to rule out a pseudo chylothorax or chylous effusion. And it is very important to send what you call routine microscopy and other labs. When you see this fluid, chylothorax fluid is always alkaline. If you see it, you will get a 7.4 to 7.8, sometimes 8 value of pH. So, and when you won't satisfy with these investigations, and if you confused with the diagnosis of chylothorax, then always do pleural fluid chylomicron. Sometimes you won't get labs doing chylomicron. You'll have to hunt and find labs doing pleural fluid chylomicron. It is very important and clear our doubt.
Right, very, very well told. And really, diagnosing chylothorax, like you told, is difficult because most of these tests, like Swadip told, उनके lab वाले pH नहीं भेजने देते. आप बोल रहे हो chylomicron वाली lab नहीं मिलती है. So I think maybe as pulmonologists, at least we should be aware कि अपने city में कहाँ पे ये चीजें properly हो सकती है, because we are the ones who will be asked to certify कि ये भैया chylothorax से क्या करो. ऐसी एक सिचुएशन है जो अभी आप सभी लोगों को बता दूं, पैनलिस्ट को, कि around 1129 people are listening to you across India. So this panel is being listened to very carefully. Swadip, I have a very big problem to ask you. Tell me one thing. CHF ट्रांसुडेटिव होता है पर कभी कभी CHF में टैप करो एंड वी गेट अ बाउंसर, एक्सुडेटिव निकल आता है. तो करना क्या है, हाउ टू गो अबाउट दैट सिचुएशन?
Sir, CHF definitely transudative होना चाहिए, but then if the patient is already on diuretics, as Pravin sir has already addressed, कि अगर patient diuretics पे होता है, in CKD patients, CHF patients, तो क्या होता है ना, उन cases में हमारा protein content ज़्यादा आता है, तो it falls under the exudative criteria as per the lights criteria. Lights criteria, मतलब exudative effusion को identify करने में it has a very high sensitivity. It has 98%. But for transudative effusions, that is where the lights criteria fails in these cases where transudative cause तो transudative effusion का है, but then we are getting an exudative. So this almost happens in 1 in 4 cases, around 25%. So CHF में there have been certain studies that they have said that you should always suspect based on clinical scenario. You take the history, you evaluate, you have an ECG, an echocardiogram, a serum NT-proBNP. These are supportive investigations that help you diagnose that yes, this effusion could be because of CHF. And there have also been in higher centers with facilities of sending pleural fluid NT-proBNP. So there have been studies, and there is a big meta-analysis also regarding that. That pleural fluid NT-proBNP value of more than 1500, if it is there, then we can label it as a CHF effusion. The effusion is because of congestive heart failure.
Right. Very well told. And really, this is one very important thing that pleural fluid pro BNP levels also अपनी उस कठिन लैब को अपने पहले को बताना पड़ेगा, भाई ये प्रो BNP प्लूरल फ्लूइड में चाहते हैं, ब्लड में नहीं चाहते हैं. So that is some very important thing. But Pravin, sometimes your lung is trapped, but still that is fluid. मतलब what do you have your views on thoracentesis with a trapped lung?
Yeah. So here a role of repeated thoracentesis comes in. So when you see all these chronic tubercular empyemas or chronic parapneumonic effusion, sometimes your lung is getting trapped. Like lung is sometimes act as a container in rigid walls. So because of a fibrinous, what you call elastic pleural rind kind of thing around the lung you can see, and because of that lung doesn't come up. So here repeated thoracocentesis has a role. You can go ahead with the repeated thoracocentesis. If patient doesn't want repeated thoracocentesis, or you have expertise in indwelling pleural catheter, then you should give option of indwelling pleural catheter to the patient. If patient is not surgically fit, otherwise only curative treatment here is surgical decortication. Either it is VATS surgery or open thoracoscopy. But here you can give option of repeated thoracentesis, but again the complications you can see more loculations when you do repeated thoracentesis. So you will have to limit your number of attempts and go ahead with newer modalities, newer interventions like indwelling pleural catheter or sometimes thoracoscopy.
Right. So, Dr. Vinod sir, Dr. Shams from Jharkhand, Dhanbad, Jharkhand, is asking us that any solution of tubercular effusion, because they develop multiple septations and they become difficult to drain. Same situation we see in parapneumonic effusions also. So, Dr. Vinod sir, ये parapneumonic effusions and tubercular effusions में thoracentesis कैसे करें?
Sir, in parapneumonic effusion and tuberculosis loculated effusion, we have to just for the diagnostic purpose, we have to do the ultrasound and we have to find which is the place where is the maximum fluid there, and we have to remove that fluid in the parapneumonic or in tuberculosis effusion. So, but in a parapneumonic effusion, we have to just first try to treat with the multiple antibiotics and all the things. If it is not treatable and the effusion developed or it's like an empyema, then we have to just do the sonography and remove the fluid from the most appropriate focus.
Okay. But that I too feel that when it is very, very complicated, then I think फिर ये इस webinar के purview से बाहर जाके ICD वाले webinar में discuss करना ज़्यादा better रहेगा.
Yes, sir.
Thoracoscopy and ICD.
Because it's restricted to the thoracentesis, but yes, ideally go with the thoracoscopy, medical thoracoscopy.
Right. Pravin कुछ बोल रहे थे? Pravin, anything to say?
Yeah. So whenever patient comes to you, sir, in my practice, I have a habit to put the probe and check for any septations or any loculations. And if septations are there, you need to go ahead with at least for ICD. If patient is willing for thoracoscopy, and if you don't have a primary diagnosis, go for thoracoscopy, get all these adhesions out, get the pleural biopsy, confirm the diagnosis, and treat with antibiotics.
Totally
मानता हूँ
agree.
भाई, पर मैं
वापस
मॉडरेटर हूँ,
वापस आ जाओ थोरैकोसेंटेसिस में।
वो मैं मॉडरेटर हूँ, वही थोरैकोसेंटेसिस तक सीमित रखना पड़ेगा। तो अब जब हम पढ़ाई कर रहे थे इस वेबिनार के लिए, हाँ हम पढ़ाई करते हैं इस वेबिनार के लिए, तब मुझे आदित्य ने बोला मिस 2 ट्रायल में ये दिया है। तो मैंने बोला क्या? तो
वो
अरे
सवाल
आप
मेरे पे।
2 ट्रायल नहीं जानते? तो आदित्य भाई अब आप ही बताओ यार, ये मान लो कोई एम्पाइमा का पेशेंट आ गया, तावड़े साहब ने उनके क्लिनिक पे सेप्टेशन ढूंढ लिए, पर उसको तो थोरासेंटेसिस से ही ट्रीट करवाना है या कुछ करवाना है, बताओ क्या करेंगे उसमें?
सर देखो, we had 3 trials, missed 1, missed 2 and missed 3. ठीक है?
बिल्कुल।
Missed 1 trial was of the streptokinase and urokinase, which is not available in India. Streptokinase is available, and I have a very good experience of streptokinase. Putting in the pleural cavity, it clears off in 5 days, and the patient goes happy home. But in the literature, I don't know what happened, what was there, but they did not support streptokinase, and they said that it does not decrease the mortality of the patient. Okay? It increases the pleural fluid excretion from the body. It increases the evacuation of the pleural fluid from the cavity, but it does not decrease the morbidity or the mortality of the patient, and that's why it was not supported. Then came the MIS2 trial. So TPA and DNase, these are both antifibrinolytics, and they were tried separately. They did not yield any result. But when they were combined, both of them in the same sitting, the patient had a significant release of the fluid from the cavity. They had reduction of the hospital admission. They had rest surgical referrals. Now, in the future time, the MIS3 is going on. They are practicing the pleural enzymes they are inserting in the pleural cavity, which are helping in the evacuation of the fluid. That is the thick empymas.
Right, right.
So this was MIS2.
No, definitely. Thanks to you, because I also read it in the NEJM article. It is very, very important because you understand how to manage this. I remember Dr. Richa Gupta मैम काफी STK के बारे में बात करती हैं, एंड CCI के अल्ट्रा ग्रुप पे ये डिस्कशन आई थिंक संडे मॉर्निंग में कई बार हमने देखा है, STK के फेवर में ये डिस्कशन काफी होता है. So nice that you elaborated it. Tell me one thing, अनीश सर, आपको हमने बहुत देर से कुछ भी नहीं पूछा. इफ्यूजन्स का रेडियोलॉजी, मतलब एज अ रेडियोलॉजिस्ट इफ्यूजन्स में व्हाट ऑल कैन यू कंट्रीब्यूट, मतलब व्हाई शुड आई पेशेंट टू यू?
In effusion, what we can see, if it is a clear anechoic effusion, it is a great probability that it is a transudative. And whenever a complex or a heterogeneous kind of effusion or a layering on the fluid is seen, or any septations are seen, it on the my first picture is that it is a it is an exudative etiology. So this is the two basic concept which I keep in my mind, and I convey this message to my referring physician friend. You see, I have seen this. Now, should I proceed to the next step?
Right. So, but I'll ask you one more question. At times, we get one finding called as pleural nodularity, or we ask you to take a pleural biopsy ultrasound guided. So, how do you go about that, sir?
See, while going for the pleural biopsy, what we look for the area of maximal thickening, where we can demarcate or localize the area of maximal thickening. We put our self-retracting BART gun, and then we try to core cut the area and send it for the biopsy. So we have to see the most dependent and the most thickened part, so that it is not breaking into, or it is not causing any injury,
Right.
iatrogenic injury.
कोई भी चेस्ट डिपार्टमेंट दो चीजों के बिना कभी पूरे नहीं होता, जो कभी मिलती नहीं है। एक है एब्राहम नीडल और एक है कोप नीडल, जो प्लूरल बायोप्सी के लिए बहुत ही प्रसिद्ध है पर हमेशा गायब रहती है डिपार्टमेंट से। सो मैंने सोचा उनका नाम ले लूं। तो एक बात बताओ प्रवीण एंड स्वदीप, ये यूएसजी गाइडेड प्लूरल बायोप्सी, प्लूरल नोडुलरिटी, कभी आप लोगों ने करवाई है? कोई इंडिकेशंस अपनी क्लिनिक में देखें? विनोद सर, कुछ ऐसा इंडिकेशन यूएसजी गाइडेड प्लूरल नोडुल बायोप्सी का करवाया है कभी कॉमनली, या सीधे थोरेकोस्कोपी पे ही जाना है?
Yeah,
Very rare. I
we
had witnessed one.
One.
yeah. In my practice, I always give options of any image guided if it is possible. If it is not possible, then always we should give other interventions options like thoracoscopy. But we have in my limited practice, I must have sent one or two patients to radiologist for only for pleural biopsies, and mostly we go for thoracoscopies.
One thing, when I was a PG, तब आदित्य भाई के जो very renowned father is father Dr. राकेश चावला सर सीटी गाइडेड बायोप्सी करते थे, और वो हम देखते थे कि अरे यार ये तो पल्मोनोलॉजिस्ट है जो सीटी गाइडेड बायोप्सी कर रहे हैं। तो तब बड़ी हिम्मत मिला करती थी। और मुझे याद है सर का मैंने एक केस प्रेजेंटेशन देखा था जिसमें सर ने प्लूरल नोड्यूल की बायोप्सी करके बताई थी। तो आज आदित्य भाई, जो राकेश चावला सर हमारे कृष्णा सर से बहुत क्लोजली एसोसिएटेड, तो वो बात आज एकदम याद आ गई। Khair, moving along, time is really short. Tell me one thing, Swadip, re-expansion pulmonary edema, something which we deeply fear. Could you please highlight us कैसे क्या करें इसके बारे में?
Thank you, sir. Sir, this re-expansion pulmonary edema, mainly इसका मतलब यह है कि suddenly we are decompressing the lungs. So because of a chronic collapsed lung, for a long duration, the lung has been collapsed due to a prolonged effusion and massive effusion. So what happens is when we suddenly decompress, the lung expands and there is pulmonary edema that happens. So to avoid it, we should ideally not remove more than 1.5 liters in that sitting. And the fluid should not be removed too quickly. You should be very gradual and gentle in removing the fluid. And the moment the patient starts coughing, or the patient has develops breathlessness and says that, sir, that I'm feeling difficulty in the chest and there is some tightness in my chest. So we should suspect these as the symptoms that the patient is saying that he is going to develop pulmonary edema, re-expansion pulmonary edema. So what happens is when we are residents, where we are very enthusiastic to do pleural fluid aspiration, and we find a massive effusion. So what can go wrong in a massive effusion? कहीं भी needle डालो पानी आ जाएगा. So what we do is in that excitement, we just go on, sir, 2 liter आ रहा है पानी, 2 liter निकाल लिया. And then what happens? Suddenly patient starts coughing and there is frothy sputum, and then patient becomes dyspneic and saturation drops, and immediately we need to take measures. So there is no specific treatment for re-expansion pulmonary edema. The best way to manage is to avoid it. And if by chance your patient has developed, then diuretics, positive airway ventilation should suffice. Very rarely I've seen 1 or 2 cases getting intubated. But yes, we should be very gradual and remove the fluid slowly and not cross 1.5 liters in that single setting.
Right.
So, Swadip, even I mentioned in the talk, pleural manometry helps to prevent
definitely
re-expansion pulmonary edema. If the pressure is dropping below -20, then we need to stop. So
exactly.
we need to put it in practice, but sadly it is not currently practiced, and those monitors which are these are not available in India. We had them brought in from USA when Dad visited ATS. So we had around 10. We used them for our study. So we have a study published on pleural manometry.
Yes. But I do agree that these are some things which we should do, but we are not. But still, best part is be careful. Try to tap only 900 ml, maximum 1.5 liter, and then stop. It is better to stop. So tell me one thing, just last couple of more topics that I would like our audience to listen to is, Pravin, pleurodesis via thoracentesis. Matlab, is it an option, and if so, how to do it?
Yeah, so here you can achieve pleurodesis via thoracentesis in two ways. One is naturally when you do repeated thoracentesis and when there is no fluid and you are approximating to pleural layers, the naturally pleurodesis is happening in most of the cases when you have mild to moderate pleural effusion and you do a therapeutic nicely dry tap. And second thing, you can attempt a pushing pleurodesis agent through a bigger bore needles inside during or after thoracentesis, but you will have to see under UHG guidance as the lung is coming up or not. But usually we don't do it because we have better drainage systems like ICDs, IPCs, and you can always have thoracoscopic guidance for pleurodesis. So ideally, not should not be done via thoracentesis when you have better options.
Right.
But it is mentioned in the guidelines.
Yeah,
They do mention in the BTS guidelines that they are trying and they are doing by thoracentesis. We are not doing it personally.
right.
Same thing. I had one more question regarding ambulatory devices, but Dr. Aditya has already mentioned the Heimlich valve in his talk. So, Dr. Aditya, there is one very interesting case scenario put up by Dr. Sushma from Nasik. If a pleural fluid report is exudative, which is neutrophilic 90%, ADA is less than 10, then what will be your diagnosis? क्या करना है इसमें?
ADA is less than 10 neutrophilic. So we need to go for infective causes.
Infective causes, basically.
Yeah, and to rule out anything else, we as interventional pulmonologists, we also will proceed for a thoracoscopy if the patient agrees.
Fully agree.
Because it can come out to be tuberculosis even if ADA is coming less than 10.
राइट. अब एक जो ईडीए पे आपने बात करी थी विनोद सर, वन वेरी गुड क्वेश्चन रेज्ड बाय डॉक्टर प्रोफेसर अजय लांजवार सर इज रिगार्डिंग द डिफरेंस बिटवीन ADA 1 and ADA 2, and he is also asking that do any of our panelists regularly follow this practice of doing ADA 1, ADA 2? So anyone in the panel ADA 1, ADA 2, are you practicing? विनोद सर, बॉम्बे में आप तो मतलब पोपला में वगैरह सब बड़ी जगह हो है.
No, sir. ADA2 is specific for tuberculosis, but routinely not practice.
Not practice.
Yeah, I'll just like to add. So in where like in Mumbai, in KM Hospital, when I used to do my residency, there our pathologists were keenly doing ADA 1 and ADA 2 because they one of their students were having the comparative study between ADA 1 and ADA 2, and they have also found a similar thing that ADA 2 is more specific to than ADA 1 in pleural tuberculosis. But I don't think so many labs are doing this. Very few labs are doing, and specifically we need to send. And I don't think these are available in other metro cities as well.
I think it's more of a kit. It is nothing more than a kit which is required, but definitely commercial viability hospitals में अब देखना पड़ती है. Thesis में हो जाता है. One or two, I think most of the questions in the question box of the audience also we have covered, but there are one or two questions which are important. Dr. Jay Raman sir from Tamil Nadu, he is asking, Pravin, you had discussed about chylothorax. So he is asking, is there any role of pleuroperitoneal shunt?
Yeah, there is a role, but in my practice, I do see very less chylothorax patient, and I have not advised any patient for pleuroperitoneal shunt. Other panelists can add to this because I have limited knowledge about this.
I had seen one case of terminal malignancy. उनको कुछ thoracic issues थे. They tried a pleuroperitoneal shunt, but it didn't work out. The patient didn't survive very long. So the final question from the audience, we have covered all the other questions. One very relevant question of Dr. Anita from Delhi is that do you consider the safety triangle in and around the mid-axillary line while going for a thoracentesis? So anybody would like to answer this quickly?
So correct, we always do prefer that we go through the safe triangle when we are doing a pleural tapping. If ultrasound is available, then sure we do the ultrasound, we localize the largest effusion and we tap it. But if there is no guidance from the ultrasound people and we need to tap the fluid, we prefer the safe triangle for putting an ICD, for putting an IPC, for doing the thoracentesis.
Right, right. So I think we have come to an end of our panel discussion. We have tried to cover almost all aspects of thoracentesis, past, present, and future. Although हमारे हाथ बंधे थे, न हम ICD की बात कर सकते थे,
ना
न
हम आईपीसी
आगे
की
की
बात कर सकते थे, लेकिन की हमने।
की है हमने। तो अनीश सर थोड़े बोर हुए, उनसे कम पूछा, बट फिर भी मैं आप सभी पैनलिस्ट से एक फाइनल रिमार्क चाहूंगा अबाउट thoracentesis. हाँ विनोद सर प्लीज बोलिए।
Sir, I would like to add, radiologist and pulmonologist are the two batsmen on other end,
वाह
because
वाह,
we are seeing all the diseases and we have to follow each other. Otherwise, one of get run out at.
बहुत बढ़िया सर, बहुत। आई थिंक दिस वाज रियली बेस्ट स्टेटमेंट, बहुत अच्छी बात बोली सर आपने। तो डॉक्टर अनीश, योर क्लोजिंग स्टेटमेंट सर, एनी टेक होम मैसेज।
My closing statement would be that he always, because in today's legally aware patient scenario, always take help of radiology, because to avoid any kind of legal implications I have seen. So it is better to seek help of a radiologist whenever in doubt. We are ready to.
बिल्कुल। तो लाइक विनोद सर टोल्ड कि ये दो छोर पे खड़े बल्लेबाज है, टीम एक ही है, वो बात याद रखना हमेशा।
Yes, yes.
तो आदित्य भाई, योर क्लोजिंग स्टेटमेंट्स प्लीज।
So we need to keep broad-minded when we are doing a tapping, that result may come out anyways, and we need to consider our options कि हमने IPC डालना है, we need to place a thoracoscopy, we need to do a thoracoscopy, ICD डालना है, so we don't limit our vision. जो भी आएगा रिजल्ट उसके हिसाब से काम करना है, एंड ये नहीं कि पेशेंट को ATT पे ही स्टार्ट करना है. एवरी प्रोलिफियन इज नॉट अ ट्यूबरकुलर प्रोलिफियन. These the non-pulmonary physician should know that.
Right, right, very very well said. So Pravin, your closing statement please.
Yeah. So as I practice in Mumbai and in slum area, I have some practice. So I see I have some limitation when you collect pleural fluid, and when you wanna send a panel of microbiology or panel of other labs, then you need to think what to send and what not to send. As Dr. Aditya has covered already, minimize your investigation
Samples.
according to your pre-test probability, and you send. When you don't want pleural fluid gene expert, don't send. That will add the cost. If you wanna send, you can send it to RNTCP in under NTP guidelines.
Correct.
And always do any pleural effusion, whether you are doing in emergency or bedside or in ward, always do under UHG guidance and learn UHG. And whenever UHG will act as a, like it I do practice in nursing homes. There also UHG, after joining me, I have got UHG machine there, and I must be using that UHG machine once in a day, and make a habit to learn. And if you have any question, always our radiology colleagues are there to help us.
Right, right, beautiful. Swadip sir, your closing statement please.
Sir, I would like to just state two things. Like thoracentesis is a very simple procedure, but the two things are that the patient should be comfortable and the doctor doing it should also be comfortable. Patient comfort comes from adequate anesthesia. You should try to make it a pain-free procedure, both during and after. And for doctor's comfort, USG guidance is mandatory. It should always be with you. While during like doing the procedure, also the USG machine should be with you in case you face any issues. You can immediately put it and put the probe and see where you are and what you're doing. So yes, both patient and doctor should be comfortable while doing this very simple procedure. And with just one simple procedure, a lot of diagnosis can be like a lot of differentials can be ruled out, and we can come to a very good diagnosis with minimal investigations, as Aditya sir has rightly pointed out. So yeah, that's what will be my closing statement.
Good. So thank you to my entire panel, Pan India, for sparing your time today and to discuss on this beautiful topic of thoracentesis. I would like to extend a big thanks to respected Dr. Krishna sir, to Dr. CVK sir, to Dr. Atri, to Dr. Shivani, Dr. Kirat, who work relentlessly for bringing us these relevant topics for our practice. On behalf of CCI, I would like to wish all of you a good night, and thanks to the entire audience for keeping with us, being with us throughout this webinar. Thank you so much.
Good night,
Thank
sir.
Thank you.
Thank you.
Thank you. Good night.
Thank you.